So when we started treating those patients with heart failure way back somewhere in 80s or late 70s, initially it was recognized that it is the heart pumping which is low and the resistance for heart to pump the blood out has to be reduced. So initial medications used to be isosorbate dinitrate and hydralazine combination, or ISDN what we used to call them. After that, we had this discovery of ACE inhibitors or angiotensin converting enzyme inhibitors, which block the pathway of renin angiotensin aldosterone system, which has gone a little out of mark or out of target, which cause the symptoms or worsening of heart failure. So those initial days where enalapril was tested against this isosorbate hydralazine combination, the consensus trial, if we remember, so that showed significant improvement in the prognosis of patients with heart failure. And subsequently, lot of progress was made. The people who were not tolerant to ACE inhibitors, we had subsequent molecules which are called as angiotensin receptor blockers, which had less side effects compared to ACE inhibitors. So all these molecules have shown a significant improvement in heart failure symptoms and improvement in prognosis. But the recent trial, which was done with a particular new novel molecule, which is called as angiotensin receptor naproxen inhibitor, it's a combination of two molecules where angiotensin receptor blocker is valsartan and naproxen inhibitor is sacubitril. So these two are combined together to give more important benefits to the patient. So the part of RAS blockade, that is renin angiotensin aldosterone system blockade, is done by valsartan. And then there is another pathway which is called as natriuretic peptides. So these natriuretic peptides are secreted by the heart to improve the functioning of the heart. What they do is they cause vasodilatation and they cause diuresis. The sad part is that these molecules are very rapidly metabolized in body by this molecule or enzyme which is called as naproxen. So the scientists thought that if we can block this enzyme naproxen, that will allow these molecules, that is natriuretic peptides, to stay in the body for a longer period of time and have their beneficial effect. So the combined effect of angiotensin receptor blockers and naproxen inhibitors was which was targeted with these molecules which are called as ARNI, angiotensin receptor naproxen inhibitor compound. And this has shown a significant improvement in a trial which is called as paradigm heart failure trial. So significant reduction in mortality when it was compared to enalapril. Remember, this was the first molecule which showed significant benefits. So this molecule was tested against enalapril and showed significant reduction in mortality, significant reduction in heart failure hospitalization, and of course symptomatic benefits. So even the NYHA class, what we commonly call, has significantly improved with this treatment of these molecules. So these molecules should be the primary aim how we are going to treat the patients with heart failure. Now there was a period where it was mandatory that we used to use ACE inhibitors or ARBs before we shifted the patient to ARNIs. But now with the recent trials, what has been suggested is that we can straight away go in a patient who has heart failure and has never been given ACE inhibitors or ARBs. We can still put in those patients on angiotensin receptor naproxen inhibitors, and that has shown significant improvement in the benefits. And we don't want to, not have the patient benefits of these molecules because they have not been tested on ACE inhibitors or ARBs. So that is one part. So all those patients who are on ACE or ARBs, even though they are stable, now this stable is also a misnomer. The patient with heart failure, as I mentioned, is always a progressively declining heart function. So there is nothing like what is called as a stable heart failure. And if you want to give maximum benefit for that patient, you need to shift these patients also who are apparently stable on ACE or ARBs to angiotensin receptor naproxen inhibitor blockade. So that is going to give you a much better prognosis for that particular patient. As I mentioned, any heart failure hospitalization is going to cause a rapid decline in heart function. So we want to prevent those heart failure hospitalizations, and that's why whatever is the best thing which is available for that patient is angiotensin receptor naproxen inhibitor, and that has to be given to the patient. So even the patients who are on ACE or ARBs and apparently stable should also be shifted to these particular molecules. The third part is these are the molecules which are going to cause significant vasodilatation and significant drop in blood pressure. So there is one worry which always keeps haunting us, whether the patient who has got admitted with acute decompensation, whether he will tolerate these molecules. And there have been a couple of trials which have tested this particular hypothesis also, and acutely decompensated heart failure patients Once they are stabilized, what do I mean by stabilized? They do not need upscaling of the diuretic dosage, they do not need any intravenous inotropes. So these are the stabilized patients of heart failure. They also can be given these particular molecules to improve the prognosis and to have a rapid good recovery of the heart failure patient. Now we need to remember two things. One thing is when the BP is low, especially in elder population, we need to start low and go slow. So start on the lower doses and then progressively increase the doses. Now the general suggestion is increase the doses or step up the doses every 15 days depending on patient's blood pressure and patient's renal function. And of course another thing is we need to monitor their urea creatinine, more importantly serum potassium, which can sometimes go up. So these are the 2-3 things which I would ask you to remember when you are treating these patients with ARNIs. But these are the wonderful molecules which should be into our armamentarium even in the patient who are apparently stabilized on heart failure treatment.